Hello everyone. Today I am operating a case of a brown cataract. So what is different about this case is that I am going to be operating it on an older machine which has issues with chamber stability from time to time. So here I would like to discuss a few things, a few adjustments which I make to be able to operate such a grade of cataract on the older machine. So not all of us have the privilege of operating on a very high-end phaco machine, and from time to time we have to manage such hard cataracts. Maybe the easier way out here would be converting it into a small incision cataract surgery. But if you want to do a phacoemulsification in such a case, maybe we can discuss a few strategies. Starting off with the rhexis, ensure that the capsular rhexis is sufficiently large. Do not think about the optic overlap in this situation. If you have an older machine and it has problems with its fluidics and it gives you intraoperative surge from time to time, it's better to play safe than to have a small rhexis and struggle intraoperatively to be able to crack the nucleus and prolapse it out if so the need arises. The issue with a smaller rhexis will be that it can predispose you intraoperatively to zonular dialysis and a posterior capsular rupture in case if there is intraoperative surge and you are unable to crack the nucleus appropriately. With a larger rhexis, if so the need arises, you can convert to a small incision cataract surgery and get out of the dodge. Ensure that the hydrodissection is complete and the nucleus is mobile as seen here. The technique I use here is pit and chop. Alternately, you can use a stop and chop maneuver, but I have stopped using it as I have noted that it gives you more of a phaco wound burn if you are not very careful. As these older machines do not have any torsional phaco, this pit and chop maneuver is very well suited. So with initial pit to get a good grip on the nucleus, you can go around the equator and get a good chop as seen here. Now even if you don't get a complete chop, keep at it and aim to produce several small chops as opposed to one big chunk. In older machines where you are getting a lot of intraoperative surge, you have to keep your vacuum quite low. In this case, I have kept it at 175 millimeters of mercury. So as you can see, the followability of nuclear pieces is not as good. The grip on the nucleus is also very bad actually. But you can make that up with a good technique. Phacoemulsification of smaller pieces causes very minimal post-occlusion surge. So in this case, I have kept the vacuum at 175 millimeters of mercury, and as you can see, the anterior chamber stays quite stable after emulsification of those smaller nuclear fragments. Emulsification of larger fragments requires more phaco energy and also gives more post-occlusion surge. So in an older machine, I find it better that you keep the phaco parameters low but make smaller pieces as seen here. As you continue with phaco, always keep an eye on the corneal wound, as there is a high chance that you start to see some phaco wound burn. and always ensure that your phaco tip is floating inside the sleeve and is not opposed against any of the cornea or scleral walls. As I proceed with phacoemulsification of the nucleus, I realize that there is absolutely no epinuclear protection to the posterior capsule. Here I refill the anterior chamber with OVD, and at the back of my mind I am trying to think of strategies to manage this nucleus safely. So what I decide is that I'll debulk the nucleus a little bit more and then proceed to insert the IOL underneath the nucleus and do an IOL scaffold. Another important thing in older machines is that whenever possible, try to use phaco power modulations. In this case, I am using a micropulse with 75% phaco energy. But at any point of time, I am not completely depressing the foot pedal and am trying to minimize the use of phaco energy by creating smaller and smaller phaco pieces. One more thing you can do is use a new phaco tip. That will help you emulsify the same grade of cataract using lesser phaco energy, as the new phaco tip is usually much sharper and hence the ultrasonic power used is considerably less. But it's not mandatory per se to use a new phaco tip each time, but if you have that option, try and utilize it. Once the IOL is inserted in the bag, I am totally relieved. Now I can emulsify this nucleus piece without any tension whatsoever, and I proceed to do so quite effectively as seen here. This IOL scaffold technique is most effective when you do not have any epinucleus in the bag. Otherwise, removal of epinucleus after IOL insertion can become quite a hassle. Now I proceed with removal of the cortex as seen with tangential movement of my irrigation aspiration cannula. So the moral of this story, if anything, is that don't be disheartened by which machine you have. Management of such a brown cataract is possible even on older machines, but it's just that you will have to adopt a few different strategies. And yes, you may not complete these cases in record time, but in most cases, with a lot of patience, you will be able to do a really good job. So don't give up. Keep innovating, and thank you for watching. That's it.